Good morning and good day to everyone who's joining us from across the globe. I'm quite excited to be facilitating this session, which is a new addition actually to our BioAfrica convention. And the session is titled Civil Society and Advocacy, specifically in the health sector. My name is Tumi Semete and I'm the CEO of SAPRA, but also board member at Africa Bio, as well as being involved in the organizing committee for BioAfrica. Today, we've got quite an elaborate panel of speakers who are going to touch on a very important aspect that many a times us in the innovation space overlook. It is the role of civil society in championing innovation, either from making a call for access to medicines, for access to health products, but also saying that they want to be part of the innovation value chain. And this morning, we thought we have this session to listen to those who are leaders in this sphere, but also those who have applied innovative business models to ensure that we have access to healthcare products. Our first speaker for this day will be Mr. Daniel Lester. Mr. Lester served over 10 years at Population and Health Research Center at PARC, where he oversaw PARC's operations and research affairs and provided strategic legal counsel to PARC internationally. He is a frequent speaker on numerous topics, especially intellectual property law. Before joining PARC, Mr. Lester was an associate professor of law at the University of Washington. Over to you, and we look forward to your talk.
Thank you, and good morning or good night, as the case is here in Seattle. So I just thought I would spend a few minutes talking about both the work at PATH, but also the work I'm finishing up right now, which is leading public-private partnerships in the state of Washington in terms of the rollout of the COVID-19 vaccination for the state. So it's on a much more local effort, but the notion of how you partner across sectors is the theme in terms of the work I've done the last well over a decade. At PATH, PATH is a US-based a nonprofit organization that's been in existence for over 40 years. And its focus is on bringing health innovation to those most in need from a health equity perspective. The organization has worked across various products, from diagnostics to treatment to vaccines. And in doing so, the thread that cuts across all of the work, there are two. One is innovation to bring it to scale and to apply those products in low resource settings. And in so doing, making sure that health equity for those most in need of health innovations and products are served. At PATH, one of the key touchstones by which we operated was that we did cut across sectors, and we had a user-centric design. And by that, the focus really was on the communities in which we were seeking to serve. So in that vein, the organization was always looking to what was the product that we needed to bring for those we were serving. And in developing the target product profile, there was always the focus on those we were serving. In terms of vaccines, obviously the footprint has to be fairly large in terms of the scale of investment needed. But on some of the other products, they really were very localized in nature. Anything to do with how to deliver healthcare very much was focused on the environment in which we were operating, whether that would be in rural Congo or parts of South Africa, East or West Africa, or in Asia. In my work at the state of Washington, it's a different example, but the reason why I thought it might be worth just noting is I was appointed by the state in January after vaccines were approved on an emergency use basis in the United States. And the goal was to, in the fastest, safest, and most equitable and efficient way, get the vaccines into the arms of Washingtonians and ensuring equity in doing so. In putting together an effort to join with the Department of Health and the local health jurisdictions, because I've worked across sectors, my job was to bring the likes of organizations such as in the for-profit space, Microsoft, Starbucks, Amazon, and other corporations that actually are headquartered in the state of Washington, along with nonprofits such as the Bill and Melinda Gates Foundation, organizations such as PATH, and also volunteer efforts to bring product to get the vaccines distributed. I'm just going to give, since I know we're supposed to keep our remarks short, I just want to give the example of innovation with a view to equity and what I call equity by design. When I started, there was no easy way for Washingtonians to learn where they could get an appointment to get vaccinated. In 6 weeks from first ideation, conception, put together a team that cut across both the Department of Health, Chief Information Officer, technologists from Starbucks, from Microsoft, from a startup company, and developed a tool, a vaccine locator tool, which interoperated with the scheduling programs of the more than hundreds of providers who each had their own scheduling programs, and enabled Washingtonians to very quickly, literally within minutes, locate by zip code those providers that were closest. The equity piece that was brought to bear was in launching this product. We launched in over 30 languages and with 6 accessibility settings for those who had disabilities and different visual needs. Coupled with this, we launched at the same time, there was a call center in the state of Washington, but there are those who don't have digital access. And we partnered with Amazon to amplify the abilities and capabilities of the call center so that for those who had digital access, they could use our vaccine locator tool. For those who were either digitally challenged or disconnected, they could use our call center, which included cloud computing, webbot, chatbot technology, and live agents, so that we were able to, for over 40,000 Washingtonians, have individuals help them, guide them through to make appointments. I think the key thing in working across sectors and focusing on equity is, from my lens, is making sure you get interest alignment and clarity of roles. And once you have interest alignment in terms of what the goals are and the mission, then it is actually exciting work to bring different players from civil society, from the corporate sector, non-profit sector, the public sector, all working together and playing to the strengths of each, and making sure that there is a commitment from the outset of developing a product, innovating in any way, that you're thinking across your user universe to serve with equity. So I'll stop there so that there is time for others to comment. Thank you.
No, thank you very much. I'm sure there's a number of questions. We're going to take questions right at the end after every speaker. Thank you. And the next speaker will be Mr. Frank, who is the President and Chief Executive Officer of Mothers to Mothers. He has more than 30 years experience in the global health community, which includes significant achievement in HIV prevention, domestic as well as global care and treatment. This also includes areas of HIV research, policy, and advocacy. He joined Mothers to Mothers in 2012 as its president as well as CEO, and leads a team of nearly 3,000 people in 3 continents who are delivering health, hope, and an HIV-free future in 10 sub-Saharan African nations. Frank, over to you.
Thank you so much, Tumi, and I will share my screen. Hopefully everyone can see that. I'll go to the slide view. So thank you so much for inviting me to speak here today. This is a very important panel, and I'd like to briefly share some perspectives and examples from our work here at Mothers to Mothers, known as M2M, as well as the efforts of other civil society stakeholders in battling HIV/AIDS on the African continent. Personally, I've been in this fight for more than 30 years, and I've been doing so for here at Mothers to Mothers, which has been doing this for 20 years now, for at least a decade. And there are many lessons learned from our combined efforts that can be applied to today's context of African health product development and delivery, and specifically equity. And in the interest of time, I'm going to select just a few. So the first is, these 4 players that I show here in this first bullet are obvious actors when it comes to delivering any healthcare solution. It's the final one, though, of civil society that is typically overlooked for a variety of reasons, including often a lack of cohesive coalitions and a focus among NGOs and activists, and civil society stakeholders often don't have the resources to play a significant role in product development and delivery. Another is activism and advocacy. And one of the things we've learned over the past 30 years in the AIDS movement is that activism, combined with full-throated advocacy, can indeed work in bringing about magnificent change. One of my favorite examples is from here in South Africa, where the Treatment Action Campaign, or TAC, organized a campaign for access to AIDS treatment. In less than 4 years after their founding in 1998, their work led to a 2002 constitutional court ruling in which the South African government was ordered to provide antiretroviral drugs to prevent transmission of HIV from mothers to their babies during birth. In the years following the judgment, TAC's campaigns were instrumental in securing a universal government-provided AIDS treatment program, which has since become the world's largest. So quite a bit of outcome for a local activist and advocacy approach. This brings me now to lessons to the organization which I now lead, of Mothers to Mothers. And in today's society, people oftentimes immediately equate innovation and products with technology. But new products and technology alone are not always the answer. Mothers to Mothers, when it was founded, saw a gap in preventing the transmission of HIV from mother to child. The products, effective antiretrovirals, were already there. They already existed, but there was no delivery, there was no market preparation, and sadly, there was no uptake. We saw an opportunity for pregnant women living with HIV to share their health and related family issues with professional peer counselors who have walked the same path because they too are living with HIV. We call it the mentor-mother model. And by professionalizing and employing peers to serve M2M's clients, we address equity by creating opportunity for women to move beyond the initial fears and challenges that come with their own HIV diagnosis to a position of strength. And we are ensuring more equitable healthcare access. Since our founding, we have reached more than 13 million clients, employed more than 12,000 women living with HIV, and for 7 consecutive years, we have achieved virtual elimination of the transmission of HIV from mother to child among our clients in 10 African countries. In fact, last year, our mother to child transmission rate was 0.8%. We have deliberately built a model that promotes engagement along a critical cascade of care, driving access to healthcare, retention in care, and adherence to treatment. Mothers to Mothers did not create, did not make, and we do not distribute medical treatments or products, but we make sure those medical treatments and products work in the hands and bodies of the intended recipients. Also, necessity is the mother of invention. The COVID-19 pandemic has required pivots and innovation galore worldwide. And in Mothers to Mothers case, this is when technology was instrumental for an innovative addition to our platform. In response to COVID-19, we had to rapidly adapt our service delivery to ensure that mentor mothers could still reach their clients in the communities in which they work, even when possible to do so, when it was impossible to do so because of lockdowns and travel restrictions. In just 9 weeks, we designed and rolled out a new e-services platform that allows mothers-to-mothers frontline health workers to provide client support via phone and a WhatsApp-based application that we call the Virtual Mentor Mother Platform, or VMMP. Using a technology already in the hands of clients, WhatsApp, our VMMP offers two-way client communications in 23 languages covering 29 technical areas. And we've already established a WhatsApp line for mothers-to-mothers frontline and country staff that provides them with operational guidelines and updates to swiftly changing conditions caused by coronavirus. And to sum up the applications in 3 broad learnings, the first is civil society stakeholders and NGOs can't be afterthoughts, but rather equal partners at the table. We bring unique on-the-ground perspectives from where clients meet services and products. Thus, we can bring innovative insights that support product development and implementation from the outset. Secondly, the best solutions are often the ones built from the bottom up, and especially those that feature community voices and engagement. We saw it during the AIDS crisis, and we are encountering it again during the COVID-19 pandemic. There are so many myths and misinformation inhibiting vaccine uptake, for example. Communities should be involved from the outset so that trust can be established and service delivery penetration is maximized. Not to mention, we're seeing a trend throughout Africa that local NGOs are being engaged at a much higher level than ever before to deliver public health services. There's a clear shift underway towards localization of service delivery. And finally, do not discount the consumer education factor. We have spent at M2M 20 years deploying frontline female community health workers to support families. They are the linchpin in creating trust with those affected by HIV/AIDS, and as such, they are incredibly valuable educational resources, especially in times like today where fake news and errant social media posts can metastasize with unprecedented speed, thus having huge negative implications on drug and vaccine uptake. And as we like to say, regardless of where you are on the African continent, who are you more likely to trust, the government or your neighbor who is a local healthcare expert? Thank you so much.
No, thank you for that, Frank. Indeed, I mean, I've got a number of questions for you, and I really look forward to the question time. The word trusted came through quite strongly, and it's an important element that we'll deliberate on in a few minutes. The next speakers we have, and they're going to tag team, it's Prof. Monique Marks as well as Michael Wilson. We've got the profile of Monique Marks, who heads up the Urban Future Centers at the Durban University of Technology. She's a trained social worker and holds a doctorate in sociology. Prof. Marks has published widely in areas of youth social movements, ethnographic research methods, police labor relations, police organizational change, as well as security. To you, please.
Can you want to start the video? Okay. Can everybody hear and see me?
Yes.
Yes. Okay. All right. So basically, we're going to be speaking. I'm going to be joined by my colleague, Michael Wilson, and we're going to be really talking about advocating and implementing harm reduction services in Durban. And we've entitled this presentation as COVID-19 as a sort of opportunity for innovations in harm reduction. And that's because really for many, many years, we as harm reduction advocates working in the field of drug use disorders have been trying to get harm reduction interventions into South Africa and accepted by governments from local to national government, but that's been a real struggle. And really COVID-19 presented an opportunity for that to happen. So just a very brief introduction to the background for this. In terms of diversity in South Africa in relation to drug use. Drug use disorders in South Africa are very much on the rise, and in particular, we have an increase in the use of opiates, mostly in the form of heroin. We think, those of us who try to make sense of this rise in drug use disorders, that it is a result of the inequality in South Africa, being the most unequal society in the world, and the fact that many South Africans, mostly young South Africans, but not only young South Africans, face what we call the burden of the future. And by this, we mean that they look into the next day and the days forward and know that there's very little opportunity for improving life chances through education, through access to the workplace, or to any other formal infrastructure, including access to health and social development interventions. In terms of diversity, drug use is, of course, incredibly interesting because it cuts across all social divides. And by this, we're referring not only to class, but also to religious divides and any other, sexual orientation, any other divides you could possibly think about. Is really where drug use is centered, and including problematic drug use. Now, you may ask how that relates to inequality and to the point about increase in drug use. Another driver, of course, of drug use is past experience of trauma, which is very prevalent in South African society. Up until COVID-19, and actually beyond that, but my colleague Michael will explain what happened as COVID lockdown occurred in South Africa. There were absolutely no government interventions that were really evidence-based or harm reduction oriented. And all the services that had been provided up until the point of COVID-19 lockdown were done by the non-government sector. Okay.
Great. So when the country entered the national lockdown on the 27th of March, 2020, cities around South Africa were really faced with a challenge of providing safe sleeping and living spaces to those who had no place to lock down. In Durban, within days of the lockdown starting, the city was really faced with an urgent public health and public safety situation, resulting from hundreds of individuals who were experiencing severe symptoms of drug withdrawal, which was very traumatic for many as a result of a forced cutoff from drug supply. And so the city, largely at the leadership of the former Deputy Mayor, Belinda Scott, actioned a private medical team to run a medical program 7 days a week across 2 of the city's 12 safe sleeping spaces, which were at Mozambique Stadium and Albert Park. The program that was started provided 260 beneficiaries with daily observed doses of methadone to help them deal with symptoms of drug withdrawal. There was also psychosocial group and individual sessions, and the team worked together with nurses from the municipality to provide daily treatment and support for individuals who were on chronic medications, many taking TB medications and ARTs. On June 1st, when the country went to level 3 of lockdown, their program was then moved to Belhaven Memorial Hall in Durban, where we have been operating for the last 14 months. In October of last year, the center was formally launched by the current Deputy Minister of Social Development as the Belhaven Harm Reduction Center, which was actually a name that was selected by the beneficiaries, and has since been recognized as a national model for the delivery of community-based harm reduction services. This launch was attended and supported by the municipality of Durban, which signaled a really important shift in the way the city approached the needs of people who use drugs in the city, from a formerly punitive and a prohibitionist approach to one that really recognized the impact and publicly supported a harm reduction approach towards dealing with the needs of people who use drugs. So today, the center is open 7 days a week and serves approximately 200 individuals on a daily basis. The center is peer-led, which means that past and current recipients are a part of the core team that assists in running the program and sit on the center's steering committee, where all decisions about the center are made. The center provides a range of services, including daily observed doses of methadone for approximately 200 people who are seeking to address their heroin use dependency. We provide a meal. We provide screening and treatment for TB, HIV, and other chronic diseases, a program which uses peers to deliver medications to individuals who are too sick to come into the center. The center has recently started a homeopathic medical clinic that's running 2 days a week, which provides access to alternative medicines at Belhaven free of charge. And the center is also used to host community events to talk about issues that face people who use drugs, their families, their communities, to hold trainings and wellness events in collaboration with our partners.
Okay, it's important, I think, moving on from what Michael's presented, to also mention that one of our key partners, the program is run by the Durban University of Technology together with Michael's organization, Advanced Access and Delivery. But a third organization that is involved in the running of the center is the South African Network of People Who Use Drugs, who really are the beneficiaries of the program, which Michael has already described. So we thought that given the nature of this panel, we'll just mention what we think is innovative about Belhaven. It really is the first comprehensive harm reduction center providing the range of services that Michael has already outlined in the country. And as Michael's also pointed out, has become, I think, a model for community-based harm reduction provision. And that's actually led us to be seen in some ways as experts in the field. And so we have been asked to do things like run CPD courses for medical and health and other sort of psychosocial professionals going forward. Secondly, our partnership with the municipality, eThekwini, means that this is now an initiative which is a sort of co-designed and co-owned initiative, which is both public and non-government. And this is really critical, because what we're trying to do is to get government at all levels to buy into harm reduction approaches to dealing with drug use disorders. We are struggling a little bit with a sustainable funding model. And so what we've done is to try to be really innovative in relation to this. While government provides us with the building, water and electricity and 24/7 security, it does not fund the actual provision of services at all, something which we hope will change. But one way that we're hoping to develop a sustainable model is to develop a second stream of beneficiaries, and that will be people who are able to afford to pay for services from the more middle class and upward groupings in South Africa. And that is underway at the moment, and we're working with National Treasury in developing that second stream. We think that the provision of alternative forms of medicine or well-being are an important innovation in a very low threshold environment, which is geared towards predominantly homeless and low income people who probably have never been able to interface with alternative medications such as homeopathy prior to their experiences at Belhaven. Where we want to go forward, which we're not doing currently, and it takes some architectural and space innovation, is to develop an overdose prevention space where our clients who are still using drugs will be able to use drugs in a place that is safe, which will be overseen by probably by registered nurses to ensure that there is no overdose that takes place. There are many names which we could call that, but we prefer to call it an overdose prevention space because it has more traction with community members who are not drug users. Belhaven is also now used for training for healthcare professionals and for peer members and for the development of skills. And this is across the professional and the student communities, because we have involved a variety of university students in Belhaven. And so really, I suppose what we'd like to position here is Belhaven as a sort of hub for learning and for generating a variety of forms of knowledges. Just out of information's sake, even though we've only been up for just over a year now, the Belhaven Harm Reduction Centre has already received a number of awards, which we think are important because it allows us, I suppose, to recognize the value of the centre and also for future funding that we do. Just to mention some of them, we did win the Human Science Research Council University South Africa inaugural Team Award for excellence in a response by the humanities and social science in response to COVID-19. We also won the Durban University of Technology Award for the most outstanding community engagement project, which of course is important in an academic world. Belhaven was also profiled by the South African Cities Network, which again is a partnership between government and non-government, as what was called a good hood story, a story about placemaking in cities. So we were one of 4 recipients of that award nationally. Thanks very much.
Thank you very much, Michael and Monique. Again, I think the 3 presentations very enlightening. I'll have my colleague Sibusiso maybe start with the questions before I come in.
Good morning, everyone, and thank you to the presenters for the wonderful presentations that they've made and the wonderful facilitation by Tumelo. I'll start with Michael and the Belhaven presentation in terms of questions. So now the question I have for you is, it's a wonderful model that you've presented. I think the question that I would ask is this a model that can be upscaled to other cities or other countries? And also, how did you get to work with to partner with government? In most instances, you might find that partnering with particularly with public entities such as the eThekwini municipality could prove to be a challenge. And then the last part of the question would be in terms of the job trainings, what are the skills that you are looking to develop or that you're developing for the clients or the people in the program? Thank you.
Okay, thanks, Sibusiso. I think let me just quickly answer your first question around, is this something which is replicable? I think what we're trying to position, and government is very interested in this, both in terms of national government and provincial and local government, is that Belhaven has proven that you really do need very little infrastructural very little infrastructure to run a program such as this. And so we refer to it really as a frugal infrastructure, which is critical in a low resource environment. So yes, it is highly replicable. I think the things that it requires is really a space, and then also the training of healthcare workers in the provision of harm reduction services, because these are interventions which are not taught either to people who are trained as, for example, medical practitioners, and that includes nurses, or to people that are more involved in psychosocial service delivery, psychologists and social workers. So it's those groups of people, Sibusiso, that we're really aiming to provide information around what harm reduction is, and also guidelines around the provision of harm reduction services, and Belhaven then becomes a model of those in action. To talk quickly to your point about our relationship with government, we have been working with national government, mostly with the Department of Health, for a number of years in developing a sort of harm reduction program for South Africa. It is very much part of our National Drug Master Plan, but there is no guidelines for interventions. And so I can say that the National Department of Health, particularly the Substance Use Directorate, does call upon civil society organizations and universities for assistance in that. But at the level of local government, I, for example, sit on as the vice chair of the homeless committee The committee is chaired by the deputy mayor. And I think it was that relationship with the deputy mayor and some of the other people in Durban, in the eThekwini municipality, that allowed this to happen. So, but also around the reputation of organizations like Michael's, Advanced Access and Delivery. Another one is TB HIV Care. And then, of course, having the university really gives a different kind of a presence, because the city does have a memorandum of understanding with the Durban University of Technology. I hope that that answers the question.
Can I just say one thing?
And Mike.
Yeah, I just wanted to say one thing, Sibiso, just in terms of Belhaven as a platform for the delivery of care for chronic medication. So yes, there are the harm reduction services, obviously is kind of at the cornerstone of what we're doing. But I also think that there has been a lot, of effort to think about what are models of care delivery to support people, particularly homeless individuals or individuals who are at a high risk for being lost to follow up or not staying on their medicines. And Belhaven as a model for not only a collection point for individuals who are on chronic medications, many of whom have had histories of medicines been stolen or are unable to wait in long queues at hospitals or clinics. So having this as an option for picking up medications on a daily basis, but also this model of using peers to deliver medicines through an accompaniment approach is something that we have gotten interest from various sites around the world. This model of daily accompaniment using peers who know where to find individuals who are staying on the streets, who have shared, lived experiences of living on the streets or living in these settings. And so I think that model is also something that we have been able to share with other cities that I hope can be replicated and scaled up as well. So thanks.
Thank you both for. Sorry, Timmy. Thank you both for.
No, go ahead.
For the responses. Probably I'll pose the next question for Frank. Frank, Mothers to Mothers has over the years done quite significant work in terms of prevention of mother to child transmission, and in terms of engaging and involving communities and members of communities, in terms of ensuring that innovations reach the people who need the most. We currently sit in a pandemic. COVID-19 is the current pandemic. Chances are there will be another pandemic or other pandemics in future, and there'll still be innovations, and there'll still be civil society organizations and communities. And then my question to you is, where do you see the space in terms of civil societies being critical in bringing the innovations and the communities and ensuring that innovations are informed by the needs in communities, more as what Mothers to Mothers has done in terms of the model, in terms of bringing in innovative solutions and also making sure that those solutions reach the people who need the most. Going forward with COVID-19 and other pandemics, what do you see as the important role or the role that should be played by civil society organizations? Thanks.
Thank you so much for that question. And definitely, whether it's COVID-19 or if it's going to be future pandemics, epidemics, and other issues, NGOs, civil society, actually have a very strong role to be able to play when it comes to making sure that community is both directly accessed, but also making sure that the voices of the community are at the table. So a couple of examples, in addition to the fantastic example from Durban in terms of the harm reduction program and making sure that individuals have access to services, and especially individuals who often don't have voices in this space in which they're providing the harm reduction services to drug users. Mothers to Mothers make sure that whether it's a new treatment, for example, in HIV/AIDS antiretrovirals, we often provide some of the initial education to our clients around what the drugs look like, what the dosage will be, what some of the side effects will be, how often will they need to be refilled in order to be able to use them. That's one example. Another example has been, for example, pre-exposure prophylaxis, a PrEP for HIV. And initially a fantastic drug. It exists, it's available, it's highly effective, but it actually has been almost a complete failure when we look at most African countries, especially South Africa, in terms of the deployment, because it was a top-down approach. And when you approach things by engaging community around matching their needs, their desires, and their gaps in access, and you match it to the services of whether it's medications or another, some other device, medical product that is available either for sale or through government services, you can actually then create a bridge. And that's a word that I think is really important, is that most NGOs, most civil society, we are a bridge. And we are a bridge between both the formal and the informal. We're a bridge between urban and rural. We're a bridge between government and community. We are able to follow up. We're able to provide extra scaffolding to make sure that that uptake of whatever it is not just dropped into the community and we expect to market and do radio and television commercials and everyone will use the product, but we can actually help individuals understand. We can give them feedback. A peer can share their experience. And that's what starts to build that trust. And Tumi mentioned that at the end of my chat, that trust is an important word. And I think that right now, and especially I'll harken back to the misinformation, the incredible anti-this, anti-that information, disinformation that exists in social media. What individuals and consumers, clients at the community level need, they need sources of trust. They need places and spaces where they know that they can ask questions, they can get information, they can follow up, and that there is an expectation that you will be there. One, to finish this answer, in one of our programs right now that we launched a program to deal with diabetes mellitus, so type 2 diabetes, here in Cape Town in partnership with the Department of Health. And we are reaching clients, largely women, but also men, who are HIV positive and have had either uncontrolled or undiagnosed diabetes type 2. And one of the things that we found is that for those individuals that had been diagnosed and they were going to clinics and getting their drugs, they were getting their blood glucose measured, they were getting tested for A1Cs, they often felt guilty, they felt shamed, they felt that they were being scolded by the formal healthcare system. And what Mothers to Mothers was able to do with our mentor mothers being trained to be able to guide, counsel, provide support for individuals in their nutrition, in their behavior, in their daily or even hourly blood glucose monitoring, their follow-ups with A1Cs, we don't do that through shaming, we do that through partnering. And a client that we were speaking to, many of them said this, but the last client that we did in terms of our qualitative research said, you know, when the mentor mother comes and talks to me, I don't feel like I have to hide. I don't feel like I have to make up what I've been doing. I can show her exactly where I failed, where I've succeeded. And every time she will tell me, great job, we're going to even do better. And I think it's that trust that's really critical and the role that NGOs and civil society play in a crucial way in healthcare.
All right. Thank you so much, Frank, for that elaborate response and explanation. I guess the next question that I'll have will be for Daniel Luster. Daniel, you've spoken about Path and the work that you have done working for Path. I guess my question is very general in terms of we're sitting in a pandemic, and what tends to happen is, in terms of technology tends to start, or technology tends to be available in first world countries. We're currently sitting with COVID-19, and we're sitting with vaccination rates that are lower in developing countries. We're seeing countries where basically people are beginning to take off masks, and because of the level of the rate of vaccination. What needs to be done to ensure that developing countries such as South Africa, which is doing great actually in terms of vaccinations, but what needs to be done by developing countries in terms of working with, I'll say, the West, in terms of ensuring that technology is transferred in real time, and also people are able to access that technology or those innovations, so that like WHO will say, if there's anyone that's not safe anywhere in the world, no one is safe. So what needs to be done to ensure that technology gets to these places in real time, or at least the time lag is not as long? I guess that's my question for you. I've seen that you've done a lot of work in intellectual property, and you've done a lot of work working for PATH as well. So yeah, that's my question for you. Thank you.
Yeah, sure. Before I comment on that, I do just want to note, in listening to the other presentations, I think there are some underlying themes that are just critical to success across the board. One is this notion of true partnering. And from true partnering, you need the trust to get the good partnerships. And it's kind of, you either have the virtuous cycle or you don't. But the need for trust among beneficiaries and their role in informing what's needed is just critical to success. And I also agree with what Frank was pointing out in terms of the role of civil society as the bridge. In terms of the question of technology transfer, it's actually a complicated one. And I think it really depends upon the specific innovation. And I think it's a long journey we're on. And it is about knowledge transfer generally and building the infrastructure to enable that to happen. And so I truly believe in the place for innovation labs in different countries, in different regions, to help build the infrastructure needed so that there can be, whether it be a drug, a vaccine, a diagnostic, so that when there's an innovation for a particular product, there is the ability in more locally to receive the technology, that the information necessary to build the particular product. So I do think we're on the right journey, and for different types of pharmaceuticals, diagnostics, and vaccines, there are different pieces of the puzzle that need to be continue to be built, so that when, for instance, you have a new vaccine, you have vaccine manufacturers and the ability to handle different elements of introduction locally. So I wish it were simpler, but I do believe it's looking at the entire ecosystem and making sure that we are building the pieces of the puzzle to enable it to occur.
Daniel, if I can just follow up on that point, I mean, you made reference to public-private partnerships, and we've seen them,
Yes.
I think, work really well
Absolutely.
in response to COVID. And, you know, so in terms of access to, you also spoke about equitable access to information. How do you see, you know, the private and the public sector work together to ensure that information really gets to those people? I mean, you know, if you have access to social media, etc., it's easy for you to get some, even though it could be, you know, as Frank says, some of it is really fake news. But how
Yes.
do we ensure that it's disseminated throughout society?
So I think it goes back to, and again, the other presenters really touched upon this, the need for, and I see this even with the trying to obtain equitable uptake of the COVID vaccines in the state of Washington. The role of community-based organizations is absolutely critical, because who do people trust the most? They trust those from their community, the influentials in their community. And so there is a critical need for the relevant and accurate information. You know, it's tried to say knowledge is power, but sharing that in an effective way through media kits, through various replicable materials to the influentials and those who are trusted within the communities. And in order to make those materials relevant, at the inception of putting those together, you need those who are the intended audiences, as well as those who will be the influentials who are communicating. They need to be at the table and helping to influence so that the way the materials are put together resonate. Because if that's not the case, there won't be that resonance and trust in the materials. I do believe that we're just one last comment. You know, with the internet, with good use of social media, we do have tools that we didn't have before that allow. I mean, they're also the same tools that are used for misinformation, but if we use them well, it truly is about empowering those to serve their communities.
No, thank you for that. And just to Frank, I mean, you mentioned the importance of a bottom-up approach in assisting in making products available. Do you think that could be a lesson for us as we're battling with COVID vaccine uptake? You know, it's like many countries, we reach a certain threshold, and beyond that, we struggle to really get the numbers to increase. You know, and if you look at the vaccine rollout, it's pretty much been very top down, right? Do you think this is an approach that we could have maybe taken?
Definitely, to me. And we actually saw that even firsthand in real time here at Mothers to Mothers in the early stages of the vaccine, when healthcare workers were being provided access to vaccine here in South Africa. We were surprised to find that even with a lot of support and education and some sessions, that many of our frontline health workers were refusing. They were hesitating to actually sign up and to get vaccinated. So we quickly created and did our own qualitative research approach to both listen, to understand what the myths, what the fears were. And for those frontline workers that were vaccinated, we worked with them on their stories. They told stories one-on-one in groups on WhatsApp, in Zoom calls with their colleagues, and we saw that the rate of uptake skyrocket. And it's that approach of thinking grassroots, bottom up, always remembering that it's one thing to have something that someone has to take, whether it's an injection or a pill or something orally, or to even use something. It's another thing to be, it's something to be told you need to take it, and it's another thing to be told that I took this was good for me, you know, trust me, let's do this together. It changes everything.
Yeah, Daniel, you want to come in?
Yeah, if I could just add, again, this is a local example here in the state of Washington, but our Latino Hispanic population is about 1 million, so it's substantial for the state of Washington. I partnered with a professor at the University of Washington in the medical school who's from the Latino community, as well as someone who grew up in a migrant farm who became a technology, had worked at Microsoft for a while, but was also affiliated with the university. We partnered with them to use our vaccine locator tool and provide them with a electronic communication, which allowed them to do text messaging to their communities, working with community-based organizations. So it goes again to having the communication be from more trusted messengers, goes to the point Frank is making. So who delivers the message becomes critically important, and having those from the community help partner and build the solutions is just critical wherever you can. Thanks.
No, thank you. I think in the 3 minutes we have left, maybe I can ask Michael and Monique, just in terms of, I mean, the keywords that I took from this session is equitable access, trusted partner, and peer model. And one of the, you know, points that were made earlier is around the need for support and funding of NGOs. And maybe any reflection in terms of, are you seeing that increase? Are you seeing, you know, the need being appreciated by those who, you know, have the financial muscle to support such programs?
Thank you so much for that question. It's really something which we spend a lot of time on. To be quite honest, Belhaven started without being planned, and how it started was, of course, because we were asked to set up this medical team during lockdown level 5 and 4, and then we were given a building by the eThekwini municipality, who wanted us to run a full-time harm reduction center with zero funding, right? And so we've been really, struggling in some ways to find the funding, mostly coming through various non-government organizations like the South African National Network of People Who Use Drugs, who we've sort of accessed Global Fund money through them and various other funding sources. But what we are trying to do at the moment, to me, is to develop a relationship with the Durban Business Chamber, to say, look, what we're doing is we're dealing with a really huge urban problem, and that is drug use on the streets, and we're finding a way of assisting people in resolving their drug use disorders, and therefore that creates a much more fertile route for investment. So we are partnering with the Durban Business Chamber, but more broadly than that, we're trying to develop this alternative model, bringing in the second stream. But we really do need people locally and across the South African national landscape to invest in projects like this, because they really are transformative in terms of the relationships that that healthcare workers have with very hard to reach population groupings, but also in terms of innovating new ways of dealing with drug use disorders. And really all our lives are interconnected. So for as long as we have people with drug use disorders, that affects families and communities and so on. And so we really are trying to make that something which is known, and to promote evidence-based intervention. So we are hoping that this platform will assist with that.
Thanks.
Great, thank you. I see that our stream is ending probably in the next few seconds. I just want to thank all of you for your time. Really very insightful. And as I say, the takeaways for me is equitable access, being trusted partners, and a peer model. Thank you so much for your time. Much appreciated.